If you have any questions, then we are happy to answer them now. And I think Rossini has been our moderator, and she will be collating these questions. Rossini, are there any questions for Kevin and me?
There are several questions. So you want me to ask them now, right?
Yeah.
Okay, so we've got Dr. Manfredi Antioco asking whether or not it's safe to navigate the needle in plane from lateral to medial in interscalene block, and whether or not there's a concern of injury to the dorsoscapular nerve or the long thoracic nerve, and whether or not there will be the need for nerve stimulator to avoid the injury to these nerves when performing such technique.
Are you going to answer that, Kevin, or I can do that? Okay, maybe I answer that question. As Dr. Chang has illustrated and demonstrated to you how you can identify the dorsal scapula and the long thoracic nerve. Yes, the dorsal scapular nerve certainly comes in the line of fire when you are doing an interscalene block at the level of the ventral rama of C5 and C6. Usually, as Kevin has very well illustrated, it usually lies in an intermuscular tunnel kind of thing, and is often seen as an elongated hyperechogenic line. So when you are introducing your needle through the, at least certainly when I'm introducing my needle, it is always a concern. But when you introduce your needle, try and avoid these white hyperechogenic areas within the interscalene, within the scalenus medius muscle, and it's a reported complication. But whether we should be using nerve stimulation in all patients, I certainly don't do that. And there are some literature in the data saying that when you introduce your needle in an in-plane, about 40 or 50% of the time you may encounter the dorsal scapular nerve. While this may be true, but I think if you are familiar with, and after today, you should be familiar with how to identify the C5 and 6 ventral rama, and you can also see how the dorsal scapular nerve offshoots from the C5 ventral ramus to come off it into the scalenus medius and then exit at the posterior part. So if you have a good understanding of the anatomy, I think it is possible to circumvent inadvertent injury to these nerves. Do you have anything to add, Kevin?
Oh, okay. In my opinion, if the doctor performed the interscalene block, I think the first one that could be injured is the long thoracic nerve, because the dorsal scapular nerve is location is quite cranial. So if if you put your transducer in the horizontal plane, actually at that level, most of the dorsal scapular nerve has already exit through the posterior aspect of medial scalene. The reason why you can see in my video, we can clearly see the dorsal scapular nerve is because I did not place the transducer in the horizontal plane. Actually, I place it in oblique plane. So at the posterior aspect of transducer is more cranial than the anterior aspect. So that's why we can clearly identify the dorsal scapular nerve existing from the medial scalene. So in this case, if you just use the regular way to scan the brachial plexus, I think if you want to injure the dorsal scapular nerve, the most likely scenario is when you perform the C5 or C6 selective nerve block, because the dorsal scapular nerve is just posterior to the nerve root. Thank you.
Yeah, I think what you say is very right. It's the two nerves are often not clearly visualized because they are anisotropic. You have to tilt the probe in a slightly more oblique orientation to be able to visualize it. And in some cases where you see it is probably what you are doing inadvertently, that you are at a more oblique plane than the typical transverse oblique scan that we do for interscalene block. So try that next time, you may be able to visualize the dorsal scapula and in particular the long thoracic nerve more often. Okay.
Yep, thank you. Another question from Dr. Wu from Guizhou. Dr. Wu would like to ask whether you have seen any interesting anatomical variations during your scanning.
I think to answer your question, anatomical variations are more common than you can even think about. So, in fact, in anatomical literature, if you look at any structure, there are more than 150 or more than 100 anatomical variations of every single anatomical structure. So, how frequently they occur? It is very, very frequent. So, to expect something to be there always is probably a bit naive. So, therefore, again, your question is very valid, but for me to be able to see all these anatomical variations in a single career is probably a little bit too much to expect. So I often see them, and some of them I've already shared with you, but I don't see them on a very regular basis. And this is, again, the main reason why I often say that you must have a systematic approach to the scan. If you don't have a systematic approach, you're never going to see a variation because you don't have an idea what you are looking at. You're only expecting the final outcome of the anatomy, and that anatomy may not be really what you are expecting.
Okay. Then we have Dr. Koki asking whether neurolysis of the individual nerves of dorsoscapular nerve, long thoracic nerve, or suprascapular nerve can be done safely with alcohol or radio frequency ablation for pain management.
Kevin, that is your area. You can.
Yeah, I think the question is very interesting, but I'm thinking in what kind of scenario where you do the neurolysis for the suprascapular nerve? Because for the long thoracic nerve, dorsoscapular nerve, and the suprascapular, they are mixed nerves. So if you perform the neurolysis, it's going to affect the motor function. So I think we can consider to use pulse radiofrequency ablation for pain management. But if you want to use neurolysis, I don't think I can not think of any clinical situation that I would do that. Yeah, of course, under ultrasound, we can clearly see it. So if you want to selectively do some intervention, I think it's feasible. Thank you.
Also, do remember that there are anatomical data now showing that when you do anterior suprascapular nerve block, the local anesthetic or the injectate can actually spread towards the superior trunk and even more proximally. So any neurolytic agent distal injection may still get its way to where you really don't want it to go, unless you are doing a more distal block like at the supraspinatus area in the relation to the scapula. So it's just a comment.
Mm-hmm. Thank you. Another question from Dr. Matthew Kuma asking you how much volume did you usually give for medial infraclavicular fossa block?
Costoclavicular brachial plexus, as I told you, we use maximum 25 mils, and this is all you would need for any proximal infraclavicular brachial plexus block, whether you are doing it at the medial or at the costoclavicular brachial plexus area. 25 mils of appropriate local anesthetic surgical concentration would be good enough.
Okay, there are several questions from the chat box and not from the Q&A box that might be a bit interesting. So for costoclavicular block, do you do a separate supraclavicular block if you are doing it for an anesthesia for shoulder surgery?
That's a good question. In fact, there are literature today now showing that costoclavicular brachial plexus block produces non-inferior analgesia to an interscalene brachial plexus block for shoulder surgery, postoperative analgesia after shoulder surgery. So if you look at How could that happen? I mean, costoclavicular block. But if you look at the innervation of the shoulder joint and the anatomical data that we have, saying that when you perform a costoclavicular block, the drug can also spread to the suprascapular nerve, uh, towards the supraclavicular fossa. To the supraclavicular fossa, it affects the posterior cord, where it supplies the upper subscapular, lower subscapular nerves. You have your lateral cord, which contributes to it. So there are many neural elements within this block dynamics that actually innervate the shoulder joint. So it's not surprising that costoclavicular block can provide non-inferior analgesia to interscalene block. But the important thing is that this non-inferior analgesia is in conjunction with a multimodal balanced analgesic approach that is standard practice today, which is good because it produces significantly lower incidence of hemidiaphragmatic paresis. Now, in the study I quoted and the study we report, it's 5%, but there are also studies showing that when you look at hemidiaphragmatic paresis after costoclavicular block, it is indeed zero. But maybe they didn't, maybe they were lucky. So I think it is low, but it is probably 5% is a reasonable estimate. It's so therefore, in these situations, you have to make a educated decision whether to use this or not.
Okay, there's another similar question from Dr. Sammer, but this time they're asking whether or not you would also add a superficial cervical plexus block to costoclavicular block for shoulder surgery.
I don't do shoulder surgery purely with regional anesthesia, but even if you are doing it for analgesia, I don't think a superficial cervical plexus block would be of much added benefit, although there are some components of the shoulder that are innervated by the supraclavicular nerves. So I think if I were to do it in my patient, I would not do a superficial cervical plexus block.
Mm-hmm. Okay. There's also a question from Dr. Hughes asking whether or not you have any experience with performing costoclavicular block in children and whether or not there are any age limitation for these blocks.
Yes, I have experience. I have done a few. I wouldn't say a lot of them because we don't see many of these patients coming with hand trauma that require surgery, like that requires extensive post-op pain relief. I would say that your age limit is how brave you are, and I think in these smaller age groups, when you want to put a needle in such a location, I think you have to be a little careful because you have to justify why you are doing that block in that location when there may be safer alternatives and in a very tender age group. So I would leave the question back to you. Is that the question arose in your mind? You have to justify why you want to do it in very young children. I don't have a need to do it in very young children.
Okay. So question from Dr. Jimmy Wang. Since that costoclavicular block is a subfascial block, what do you expect the injection pressure to be like? And is it reliable to feel it without a pressure meter?
Well, that's an exceptionally good question. It's a difficult question to answer, but I can tell you by practice, by experience, is that when we use the injection pressure monitors, they really didn't help a lot. And because your needle tip could be against the connective tissue barrier, if you may, or it could be against the muscle, or it could be against the connective tissue layer. Without being inside the nerve, you could still have a relatively high injection pressure. You could see that thing would shoot up. And this has also been shown with respect to interscalene blocks and other areas of brachial plexus blockade. However, when you inject with the hand, your syringe, there are also data saying that using your hands to estimate the pressure at the tip of the needle is very, very inaccurate. So I think you have to use common sense. When you use ultrasound, we are not relying on only the injection pressure. You're looking at the ultrasound, you're looking at the injectate, how it spreads in relation to the area that you have placed your needle. So if you inject and you don't see any injectate spread, that usually intravascular unless proven otherwise. That's what I teach my fellows and residents. Secondly, when you inject and you don't and you see a good spread, that means it is extraneural, whatever. If it inadvertently, unfortunately, if you place the needle in the nerve and you inject a small volume, and you see swelling up of the nerve, then you must abort that injection. Hopefully, no untoward side effects, neurological sequelae will happen, but you got to monitor that patient. It's when you inject large volumes of local anesthetic into a nerve, that it may cause harmful effects that may be devastating in the postoperative period. So I think you mustn't rely on one single monitor or the injection pressure, because it's been shown to be very non-specific. It can happen, high pressures can occur because of many different reasons.
Okay, thank you. I think that's pretty much the question from the Q&A box, but I have a question myself from Professor Kamaka.
Okay.
So you mentioned that you usually perform selective trunk blocks for surgeries up to the entire upper limb. So I recently had a surgery for mid-humeral fracture, which the surgeon performed an open reduction internal fixation. But I noticed that they actually did their incision from the medial side of the upper arm. So since that area is innervated by the T2 dermatome instead, I wonder if you have any experience with such surgeries and whether or not selective trunk blocks were adequate to perform anesthesia in these procedures.
I would say that's an unusual situation where the surgeon is approaching it from the medial side of the axilla or the arm. Usually these surgical procedures are done placing a guide wire into the humerus, and then they bypass the fracture site, and then through that guide wire they place an intramedullary nail. The interlocking nails are then placed at the shoulder, as I showed you in the picture. And then a distal interlocking nail usually goes in at just above the condyle, so in the lower part of the humerus. So very rarely or unusually they go through the medial side of the arm. So if you have one that they're going to the medial side of the arm, then I think you're at a loss here. Your SETB or supraclavicular block or whatever block you do is not going to be adequate for your surgical anesthesia. You might have to supplement it with a intercostal brachial nerve at the level of the conjoint tendon, latissimus dorsi, etc.
Okay. There's also a relevant questions that's related to mine. So Dr. Olsen-Wu is asking whether Dr. Kamaka and Dr. Chang has suggestion on a reliable way to block the intercostal brachial nerve proximal to the axilla.
There you go, Dr. Chang.
Okay. Because I'm a PM doctor, so I have no experience of nerve block over this region. But as far as I know, actually the intercostal brachial cutaneous nerve has anastomosis with the nerve anterior to it. For example, the medial brachial cutaneous nerve, especially if you trace the nerve to the more distal part. So in my opinion, I think, we can find because cutaneous nerve has a pattern of, it's a small nerve fascicle surrounded by some fat. So you can use that pattern to recognize this is the cutaneous nerve. But if you want to clearly validate this is the intercostal brachial cutaneous nerve, I think you need to use a nerve stimulation. Otherwise, another way is, okay, you find all the cutaneous nerve at the fascial plane and then you block them all. Yeah, it's my opinion.
Yeah, I think what you say, Kevin, is right. If especially the question says above the axilla, then you have to come through the upper part from the pec, from the more from the serratus plane kind of from an approach from a lateral. And one such technique has been described in the literature where they inject it superficial to the serratus anterior muscle. So you're injecting it in a plane, using a larger volume of local anesthetic. Also, what Kevin mentions is very true, because in some of our ongoing studies, we often find that without an intercostal brachial nerve, you will find that in about 30–40% of individuals, you find that the area innervated by the intercostal brachial nerve is sometimes patients will report loss of sensation in that area. And I think this is because of the communication with the medial brachial cutaneous nerves and some of the other cutaneous nerves in that area. So with the same analogy, you could do an intercostal brachial nerve, but still your patient may still report tourniquet pain or pain related to that area, because this area is a watershed zone. So sometimes a subcutaneous injection just deep to the subcutaneous tissue and superficial to the deep fascia in the axilla actually takes out most of these medial brachial cutaneous nerves. And they are quite effective when it comes to tourniquet tolerance in most of these patients.
Okay, thank you. I think that's pretty much the questions that we have from the audience.
Okay, I think I'm sure you'll have many more questions, but we need to have a little time off here. So I take this opportunity to thank Kevin. You've been a great champion. Keep up the good work, and keep supporting the ISSPS, and I'm sure we will see you again in the near future. For those of you who are truly interested in small nerves, musculoskeletal imaging, look up Dr. Chang in Google, and you will be surprised. Not surprised, I would say. You'll be amazed to see all the lists of publication that he has done in this area. Thank you again, Kevin. So for the rest of you in the audience, we'll have a 15-minute break. So it's 8 p.m. in our time. So 15 minutes later, we will come back to you all with a live demonstration of some of what I talked about with the SUD, the SETB, and the costoclavicular, and some of the medial infraclavicular anatomy in a systematic way. We will do a live demonstration of this. Okay, thank you for now, and see you soon.